about more about emotional awareness and expression therapy. I know there are people from all over Sweden. I also know that actually there are people from other Nordic countries listening. I think some people from Denmark, some people from Norway, and we're really glad that you're with us as well. My name is Daniel Marotti, and I work part-time as a clinical psychologist and part-time as a PhD student at Karolinska Institute. So today we will listen to Dr. Howard Schubiner, who have over 30 years of experience working with patients with chronic somatic symptoms. He is also a researcher and have written several books and articles about the subject. And of course, he's one of the developers of the treatment called emotional awareness and expression therapy. Howard will give his presentation, and there will be possibility to ask questions at the end of the presentation. So please stay muted during the presentation. You can also write your questions in the chat, and I will read them and I will present them to Howard. And before ending today, we will also hear some words from the chairman of the Swedish EAET Society, Josephine Ek, who will tell us about what's up next and what plans the Swedish EAET Society has. And just let me present the board of the Swedish EAET Society. We have the chairman, Josephine Ek.
Hi, hi.
And we have other members of the board here, Rosmarie Widlund.
Hello, everybody.
And Henrik Hallberg.
Hi, everyone.
And Stina Björngrim. And Robert Johansson.
Hello, hello.
Hi.
But most important today is the presentation of Dr. Howard Schubiner. I'm very glad that you're here with us, Howard, and I'm excited to hear what you have to say about how to handle or treat patients with chronic somatic symptoms.
My turn?
Sure. Your
okay.
Turn. Yeah,
Thank you. Thank you so much for having me. I'm so excited to be here. And can you hear me okay? Volume's
Yes.
all right? Good, good. That was a test. I'm watching the screen. I see people shaking their heads. That's good because it's very hard to speak to people you can't see. And you know, it's kind of like a rock concert. You know, the musicians play better when the audience is interested and engaged and rushing the stage and dancing and crowd surfing. So don't do any of that. We can't crowd surf in COVID at times, I don't think very much. But please stay engaged if you can. I love speaking. I love speaking about this. It's an honor to be with you and be part of this small but growing movement of EAET. EAET actually was stolen from ISTDP. We like to call it ISTDP Light. I do anyway. I'll tell you the first time later in the talk, I'll tell you how I learned it and what happened when I had my first patient. And after studying very intensely with Alan Abbas, and if I say Alan Abbas, most of you might know who that is, I presume. Yeah, I studied very intensely with him for 3.5 days. So it was a very brief course. You're supposed to smile, that was a joke. Anyway, so why don't we get started? So yeah, and please feel free to use the chat. I like watching the chats even while I'm talking. I'm very multifaceted speaker, and I love to, and it's actually better if I stop, because if I just keep going, it's kind of like a drone, you know, on and on listening to a talk. But if you have questions that you put in the chat, and Daniel, you can kind of alert me. You know, you can put your like hand up or whatever, one of those signals on Zoom, and or even interrupt me is perfectly fine. I'm happy, more than happy to stop and, you know, chit chat or answer questions. I think we'll have enough time to cover what I want to cover without any doubt. I'm gonna talk to you about the neuroscience of pain and how we can distinguish central pain from peripheral pain, and how it's easy to do, and how all therapists can, and in my opinion, should be doing that to help their patients better understand what's going on with them. And it's not just pain, it's fatigue and insomnia and anxiety and depression. And we're going to have a break, and I'm going to show a series of videos to demonstrate two techniques that we're basically using. One is PRT, pain reprocessing therapy, that I want to introduce to you and show you how easy that is to do. And then EAET, of course. And then we'll wrap up. Okay?
So Howard, roughly,
Yeah.
when do you think the break will be, just so people know?
Oh, the break would be at, I guess you starting at 1, right? It's 1 o'clock there, roughly, a little after. So the break would be at 3, roughly.
Okay.
Is that okay?
Sounds great.
Good. If you can stand that long. If not, we can do it a little earlier. Let's see. Okay. Here we go. Okay, you with me? Video or the slides are up. Thank you. These are my disclosures, some books that I've written. Hidden from View, of course, I wrote with Alan Abbas. I'm doing some consulting these days for a bunch of programs that are trying to get help people work on this issue. Let's start with the case. So I'd be interested to see if this case kind of rings true for you, or if you see people like this or not. This is a very common American patient. 55-year-old man with neck and back pain for 11 years. He has a history of headaches beginning in his 20s. He had one episode of depression in his 40s. It was briefly treated with a serotonin reuptake inhibitor. He sustained an accident on the job where he fell and hit his head on a railing. He didn't lose consciousness, but had a bruise on his head. A CT scan of his brain was normal. He was hospitalized overnight. He was discharged, and he had head pain for 2 days in the area of the bruise. 6 days later, he developed neck pain that persisted. He still has neck pain 11 years later. 6 months later, he developed low back pain without a precipitating injury. So what I was saying earlier is that my thoughts on patients like this are that it's very easy to determine what the cause of his pain is. Is it coming from neural circuits in his brain, or is it coming from a disease in his body, or some combination of the two? And so there's 4 slides on this patient, and this first, and toward the a little bit later, in about 45 minutes, I'm going to go back to this case. I'm going to ask you what you think based on this history. So there's like 5 on this slide. There's 5 clues to what the cause of his pain is, roughly. He sought medical treatment. He had physical therapy once, no benefit. He had 3 other courses of physiotherapy. His MRI of his neck and back revealed degenerative disc disease at 3 levels, a moderately large bulging disc at C5-6, facet arthropathy, which means arthritis, mild spinal stenosis, which means the disc is bulging and pressing back on the CSF, the area, the spinal cord, basically. Foraminal narrowing, which means a narrowing coming out of the sides where the spinal nerve roots come out from the vertebrae, and these little narrow canals, there's more narrowing there. That's in his neck. In his back, his lower back, he has spondylolisthesis, which means a slippage of one vertebrae on another. Degenerative disc disease at 4 levels, 2 small bulging discs without foraminal narrowing. There's a lot of stuff going on there. He had 3 series of back and neck injections, but that didn't help. He had surgery on his neck, but the pain got worse. Why would that be? We'll discuss that. His pain now is 6 to 7 out of 10 most days, despite treatment with gabapentin, Norco, which is an opioid, and Cymbalta, which is a serotonin and norepinephrine active drug. He's considering an implanted spinal cord stimulator because his pain is so disabling. So he's in pretty bad shape. He's been unable to work since 11 years. He's involved in our workman's compensation program. He initiated a lawsuit against his company, which is still ongoing. He lives with his wife of 28 years. One of his children has a substance use disorder. He used to have a drinking problem himself. His father was abusive to him as a child. His father passed away 8 years ago, and his mom is now elderly and needs his help. And finally, the neck pain is intermittent. It comes and goes over the course of every day. It's increased by head movements, and it's worse when it's cold outside or rainy. The lower back pain is constant, but at times the pain shifts from the right side of his back to the left side of his back. The pain also radiates up to his mid-back sometimes. This lower back pain is worse with bending over, sitting in certain chairs, but not other chairs. Okay, so that's the case. There's about 12 clues in there that we'll go over it in a few minutes after we teach you how to be fantastic assessors. One thing I didn't find out, what do you think, guys, is the rough estimate of the people on this call in terms of mental health providers or physicians? If we just take those 2 kind of categories, Robert or Daniel, what do you think? Roughly, do you have any sense, or we don't know?
I have no clue.
Oh, okay. There's a lot of people out there. Great. All right. Anyway, the way I'm speaking, I guess the reason I'm thinking of that, the way I'm speaking is I'm speaking as if I'm mainly talking to mental health providers, therapists. And so that's kind of the tone that I'm taking. If there are physicians out there, which I hope there are, I hope you don't feel condescended to in this tone, but I teach the same talk, whether I'm teaching to physicians or mental health providers or the public. It's really all the same data. Okay, so the US has tons of pain. Pain has become epidemic all around the world. In the US, there's more people in chronic pain than cancer, heart disease, and diabetes combined. There's more money spent on chronic pain than cancer, diabetes, and heart disease combined. If you take back pain at around 30% and neck pain at 15% of the people with chronic pain, almost half the people in chronic pain are in this category. 15% roughly is people with head pain, headache pain, migraine, and tension headaches, and other headache forms. Irritable bowel syndrome comes next, and then facial pain, such as trigeminal neuralgia would be one of the main causes of that. Chronic widespread pain, which we tend to call fibromyalgia. In Britain, they tend to call it ME. And then other forms of pain. So, did I hear an interruption, or are we good to go? Keep going. In the US, we are doing a tremendous amount of invasive procedures for low back pain. These have all increased dramatically in the past decade or 2. And at the same time, we've had an increase in disability from low back pain, an increase of number of people with back pain. It's estimated that the number of people with chronic back pain has doubled in the United States in the last 20 years. There's studies on surgery for back pain. And when you do randomized controlled trials, there is no difference between surgery and conservative therapy for low back pain. Yet in the US, we're spending roughly $20 billion per year on surgery for low back pain. And it is our belief in my community of physicians and therapists that a lot of this is unnecessary surgery. Very invasive, very long rehabilitations, potential for harm. And this patient that I presented to you, his pain got worse after surgery, after he had neck surgery. And it's estimated that about 1/3 of people have surgery for neck or back pain are better, about 1/3 are the same, and about 1/3 are worse. So 2/3 of patients are not actually benefiting from that kind of surgery. We are doing a ton of injections for back pain, and injections work in the sense that many people have lowered pain, but when you compare injections for back pain in a broad sense with placebo injections for back pain, you find that the difference is very small or non-existent. So we're doing invasive procedures for a placebo response, basically, if that makes any sense. It doesn't make sense, but if that's how I would basically understand it. Psychological treatments for back pain. Well, the most common psychological treatments for pain are cognitive behavioral therapy and ACT, acceptance and commitment therapy, and BT or just behavioral therapies. And what these studies show is that there are very weak, weak effects on reducing pain. I see somebody put a little line. I don't know if it's an underlining line or if that's a crossing out line. That's funny. Does you see that?
It's a Freudian.
That's great. Cross that out. You know, and in fact, and we'll talk about this, but in fact, the psychological treatment for chronic pain is actually not designed to make pain go away. It's designed to help people cope with pain better. And that's part of the issue that we are trying to correct. So what about mindfulness? Mindfulness is probably I've been a mindfulness teacher myself for 20 years now. I think everyone should learn mindfulness. Every child, every school child, every adult, every person, every teacher, every therapist. But the data on mindfulness for chronic pain is not very impressive. And when you compare mindfulness studies of using mindfulness for chronic pain with CBT for chronic pain, the differences are none. And the long-term data for using mindfulness for chronic pain appears to show very little effect, which is sad. It's depressing. It's worrisome. What's going on? Because mindfulness is fantastic. Why wouldn't it work for chronic pain? And we'll talk about that in a second. I think there's a simple reason for it. How do we know what the problem is with this guy that I presented to you? He had degenerative disc disease in many areas of his neck and back. He's in his 50s. Well, it turns out that 80% of 50-year-olds who are healthy and have absolutely no back pain have degenerative disc disease on an MRI of their spine. 80%. It's normal. It's not an abnormality. It's a normality. And disc degeneration does not actually cause pain. It's kind of like when you're young, most people's hair is not gray, but you get older, your hair tends to turn gray. But it's not a disease. It doesn't hurt. I mean, it hurts a little when you look in the mirror sometimes, but it's not. It's not a disease. Same with wrinkly skin. Wrinkly skin is not a disease, but that's what happens. So this is basically wrinkling of the spine or graying of the spine that we're seeing on MRIs, but we're calling those as diseases of the spine. And we're attributing people with back pain to that. We'll talk more about that. Disc bulging, 60% of 50-year-olds have disc bulging with no pain at all. Even disc protrusions or herniations, 1/3 of people have that with no pain at all. So, and we know that disc degeneration increases with age, obviously. You see it's 50% in 30-year-olds, 90% in 70-year-olds, but the back pain in the whole population does not increase with age, interestingly enough. It goes up to the 30s and 50s and then it plateaus. And this is true in several studies around the world. So, the world of chronic pain, the psychology, and I'll try to offend everyone here. So if I haven't offended you yet, be ready. I will, because that's what I do in a loving way. Chronic pain is assumed to be biological and psychological. All pain is presumed to be this combination of biology and psychology. It's presumed to be central and peripheral at the same time. And my view is that's not true. and I'll explain why I think that in a minute. And therefore, the treatment is multidisciplinary. We'll treat the body, we'll treat the mind, we'll do a little bit of this, we'll do a little bit of that. A pain clinic will have psychologists, we'll have people who inject the spine, people who give medications, people who do physical therapy, people who do acupuncture, people who do massage, all sorts of things, put it all together. But the data on the outcome for chronic pain centers is that pain is managed, which is its goal, but it's not eliminated. And patients really don't want their pain managed. I don't know how many of you have been in chronic pain. I have, at least for, on and off. I had neck pain for years. Managing it is not what people want. So we haven't been really effective in actually reducing pain. So why is that? Well, the reason is that chronic pain is viewed as a diagnosis in and of itself. You have chronic pain. That's a diagnosis, but it's not a specific diagnosis. It's what you know. You know you have chronic pain. You don't need a physician to tell you that. But the cause of it is unknown and it's not delineated. And because of that, the treatment is geared, as I said, toward coping or living with the pain rather than reducing it. And finally, emotional processing is not actively encouraged in many chronic pain centers and psychological treatments. So what percentage of these chronic conditions are actually brain induced? So now what I'm doing is, instead of saying everything is together, everything is a mush of central and peripheral, of brain induced and peripheral problem, I'm saying, I think we can distinguish the two. Certainly anxiety and depression cause physical symptoms. When you're anxious, you can feel it in your body. When you're depressed, you can feel it. And that's part of the basis for ISTDP work and EAET work, especially ISTDP, because you can feel that. But the problem isn't in the body. The problem is in the brain. The problem is in neural circuits in the brain that have been learned and reinforced and reactivated and triggered and have become so well learned that they become chronic sometimes. Well, the same is true for fibromyalgia or ME. There's no disease in the body, and there's just no evidence of that. And we know that in our work, certainly, this disorder can turn on and off. If it turns on and off, well, what's making it turn on and off? Physical damage doesn't turn on and off like that. Irritable bowel syndrome, there is no disease in the body, because that's when you make that diagnosis. You're saying the tests are normal. Headaches, migraine headaches, tension headaches, the tests are normal. When I say tests, I'm talking about structural problems. So when you do a CT of the brain or an MRI of the brain, you're not finding a vasculitis, a tumor, an infection. You're not finding tooth disease or sinus disease or ear disease, and you're left with what we call, the neurologists call, of course, primary headache. Primary headache is, in my view, a reason. It means it's neural circuit. It means it's your brain that's generating this pain, which means if we can change the brain, we can eliminate the disorder or dramatically reduce it. Pelvic pain syndromes are commonly thought to be biological because there's a bunch of disorders that are named like pelvic floor dysfunction. Oh, the muscles are tight. Well, of course the muscles are tight, but why are the muscles tight? Because the brain is making them tight, etc. And then chronic neck and back pain. All these chronic pain syndromes are roughly 90% are neural circuit or brain induced. Well, chronic neck and back pain is presumed to be 90% physically induced because of this reliance on MRIs and interpreting them in a way which I just showed to you is faulty or myopic, in my opinion. And so people who've looked at this very carefully, and I'll show you some data later from one of our studies, we believe that chronic neck and back pain is primarily a neural circuit or a brain-induced problem, which is why these disorders, even though they seem to be medical, we would think if you have a back pain, you think that's a medical problem. If you have pelvic pain, you think that's a medical problem. But if you have anxiety, you think that is a psychological problem. I think these are all, in a sense, psychological problems for the most part. Okay, you guys with me? So, any questions at this point? Should I look in the chat box? Does anybody want to unmute and ask a question? There's a bunch of chats here. Should I look there? Robert? Someone said, I thought fibromyalgia would be 100%. Yeah, it is 100%, but I always say 99 because you never say never. You know, there's going to be some person who is misdiagnosed or something, but yeah, I would agree with that. ME is, what do they, you put myalgia encephalomyelitis. Yeah, that's what we're talking about. Other questions at this point? Anyone? Robert, you're sending me a signal, but I don't know what that signal means. I mean, Daniel, you are.
Daniel, you're pointing at something. You're muted, Daniel. Daniel, you're muted.
Daniel, you're still muted.
There was a question from Lotta who wanted to ask you about the label that you talked about on the facial pain syndrome.
Oh, I mentioned trigeminal neuralgia. That's the disorder that, one of the disorders that is the most common facial pain syndrome is called trigeminal neuralgia. Again, it's a medical name. It's trigeminal nerve. The fifth of the cranial nerves is damaged, it's diseased. And you get an MRI of the inner ear area, the ear, and you look, and there's a vessel that's pushing frequently on the trigeminal nerve. So this sounds like, you know, you need surgery. Well, surgery for trigeminal neuralgia is not that effective, just like surgery for back pain is not that effective. So it's not like if you have appendicitis, you take your appendix out, it works. It's, you know, it's not a question. So anyway, it turns out that a lot of people, just like with back pain, have MRI evidence of vascular compression of the trigeminal nerve who don't have any pain. So, and the other thing about trigeminal neuralgia, which is what this patient, I'm going to show you a patient with that actually. So we'll get to that a little bit more later. I see a question in Swedish, which I don't understand. Oh, it's oh, I can understand it. Trigeminous myalgia. Got it. Hey, I can speak Swedish. Okay, any other questions or should I move on? I'll take that as moving on.
Sorry to interrupt. Someone is asking about if it's possible to get a slideshow afterwards. And I think Josephine linked to a lot of, Howard has been very generous in sharing a lot of material with us. And I think Josephine put the link up on the Facebook page.
Yeah, they are on the Facebook page connected to the event during and beneath a tab called discussion. They can find the slides and some other materials.
It's so kind of you to say I'm generous. Sharing, share slides. Oh, generous. What else? Exhaustion disorder. What is exhaustion disorder? Oh, is that chronic fatigue, what I would call? Someone asked about exhaustion disorder.
Exhaustion disorder is a stress-related disease, which was coined here in Sweden. And,
oh, I'm familiar with that. Given up syndrome.
Yeah, sure. Or it's it's a stress-related disorder where the long-term stress actually gets you exhausted, and the people have a chronic fatigue as well. Then.
Yeah, I mean the story that, you know, my understanding, you would know it much better than I, but my understanding of the story was there was a child in Sweden whose one of his friends got deported, and he became catatonic, and then another kid became catatonic, and they had to feed him with a feeding tube because he couldn't move or talk or eat or anything. Isn't that? And I was told that had a name, something like giving up syndrome.
No, it's not the same thing. However.
Oh, okay. Sorry.
I think it's this exhaustion disorders comes from when someone told me from burnout and.
Oh, okay. Yeah.
Yeah.
For sure. Yeah, it's the same. Okay. Are we still on screen sharing? You still see the slides?
No.
Oh no, I have to go back to screen sharing. Okay. Let me do that. Oops. Now? Yes, no?
Yes.
Okay, are we good?
Perfect.
Okay, great. Thank you. Even better than good. Actually, do you know the saying, perfect is the enemy of good? It's one of my favorite. Okay, so let's talk about the brain and pain for a moment. And the concepts that I have found most useful for understanding, in essence, the neuroscience understanding of how the brain works is predictive coding. So if I say that, predictive coding, I'm just wondering, I don't know how to take a poll. Can you take a poll? Can we take a poll? Do I have to stop screen sharing to take a poll? I wonder how many people, if I say predictive coding, are like, oh yeah, predictive coding, or like, what's that? How do we figure that out? I don't know. I guess I should be a better Zoom presenter. Can we take a poll?
I was trying to do it here, but it doesn't seem to work.
It's not working. I can see all the participants. Maybe you need a higher level of Zoom to take a poll.
People are writing on the chat.
Oh, good.
And they say, most of them say yes, no idea, or question mark, or not sure, or no idea.
Okay.
Oh, here's the poll.
Oh, we did it. Oh my God, that's so cool. Wow. Okay, I think it's overwhelming. Wow. This is just like watching the votes come in on the presidential election we just had. You know, people were refreshing their screen every 2 minutes. What's it's very
Was this the question you wanted to ask, Howard? Do you know what predictive coding means?
Yeah, that's the question. Yeah, perfect.
I think you got a
Thank you. Thank you so much. Okay, great. Well, I'm really happy to present this. Are you still on my screen share?
No.
No. Okay, so let me go back to that. Okay. Okay, now? Yes, good?
Very good.
We're good, okay. Almost perfect. Not perfect, but good. Okay, so what about the brain? Well, you know, conversion disorders used to be, in historically speaking, conversion disorders where people would have inability to speak or see or move their arms or legs in the presence of completely normal neurological function is a conversion disorder. These used to be way more common than they are now in modern society, yet we still see them. I had a patient a while ago, a teenager who was being bullied at school, and his arm was dead. He'd wake up in the morning, his arm was fine. He'd go to school, his arm was dead. He could not move it. Completely impossible to move that arm. He'd have it in his sling. 3 o'clock in the afternoon, he'd leave school, his arm was fine. His brain was obviously causing his arm to be dead in relation to a psychological disorder. PNEA is paroxysmal non-epileptic attacks, which are what we used to call pseudo-seizures. So people look like they're having a seizure, but it's completely psychological event. Symptoms can be contagious. There's a very famous study from Germany where they found that back pain was lower in East Germany than West Germany at the time of the fall of the Berlin Wall, and then back pain increased gradually over time to the same, roughly the same levels of back pain in Western Germany as the populations mixed. And how many of you have hallucinations? We think about hallucinations as being abnormal. We think about hallucinations as being uncommon. We think about hallucinations as being in people with psychosis, yet most people, I don't know about you, but I have felt my cell phone vibrating in my pocket when it actually wasn't on several occasions. That's a hallucination. Our brain creates what we experience, and that's the essence of predictive coding. Our brain creates our internal experience. Our brain generates what we feel. So what about pain? How does pain fit into this? Well, pain is a protector. People who are born without the ability to feel pain often die at a young age or have severe injuries because pain protects us to let us know we're injured when we're injured, so we can stop doing what we're doing. But when you touch a hot stove, the reason you have pain is not because of your finger. It's actually because the brain decides to turn on pain. So if you're running across the savannah trying to chase down a deer, which our ancestors used to do 100,000 years ago or so or more, and you break an ankle, you want severe pain, because if you don't get severe pain, you'll keep running on a broken ankle and ruin your ankle. So the pain is there obviously as a protector. But if you're running and you're being chased by a lion and you break an ankle, now you don't want pain because you will die. And chances are your brain will not create pain in that situation because there's something more important. In other words, pain is a decision that the brain makes. Pain is an opinion that the brain creates. This is so important to understand, and this is the essence of predictive coding. So another example of predictive coding that I like to tell is my wife has the same breakfast every morning: sliced apple, yogurt, granola. And a couple years ago now, she woke up early. She had an extra slice. She brought it up to the bedroom, and it was dark. I didn't see it. She just gave it to me, and I took a bite of it without seeing it. And I bit down on this apple, and I got this rotten taste in my mouth. It turned out she didn't have an apple that day. It just happened to be a peach. And I love peaches, and the peach was sweet. But my brain ignored the sweetness of the peach, and it paid attention to the softness of it, which was unexpected because my brain was expecting the crunch of an apple. And my brain was trying to protect me from eating a rotten apple because it was soft. And it created a sensation that wasn't there. It created rotten sensation, but I was actually tasting sweetness in my mouth. Our brains create and generate everything that we feel. And it's how vision works. And so vision works by, if I gave you prism glasses that turned the whole world upside down, you'd seen everything upside down for a few days, but your brain would then turn things right side up again, because our brain, we don't see with our eyes, we see with our visual cortex. And so our brains are creating what we experience, what we see, what we hear, what we feel. And there's tons of examples of this that I don't have time to go into right now. But when we get back to pain, I have 3 pain stories that I tell all my patients. The first one is this one. A friend of mine shot a nail in his hand by mistake. He was alone at a construction site. He had absolutely no pain. How can you have no pain with the nail in your hand? Well, probably, and it's not something you can choose, because the subconscious brain, where the danger alarm signal is located, our protective measure, the neuroscientists call the salience network, and it's not a region of the brain, it's a network. And so his brain did not turn on pain, probably because he was all alone. And his brain had to decide, again, an opinion, whether he should drive to the hospital or be alone in pain. His brain chose drive to the hospital. It didn't turn on pain until later. This guy was a famous patient from Britain who stepped down on a nail that pierced all the way through his boot. He had tremendous pain. They rushed him to the hospital. They gave him IV pain medication. And yet when they took the boot off, there was absolutely no scratch on him. The nail went right between his toes. His pain was real, because all pain is real. And his pain was generated mistakenly by his brain. His brain was predicting that he should have pain because he had a nail going through his boot. And his brain, and that shows that real pain can be, and as I've pointed out, is typically, or is often, created by the brain in the absence of a physical injury. And the third story, just like I feel I have to apologize to the world for our president, I feel like I have to apologize to the world for the Vietnam War, because I gave some talks in Vietnam last year. And anyway, so a friend of mine was in the Vietnam War, and he got ambushed his company got ambushed one day, had a lot of injuries, a lot of guys died, and he had shrapnel wound to his leg and had a lot of pain. He got medevaced out. So he comes home. What happens to his injury? Of course, they heal, because all injuries heal. And his brain turned off the danger alarm signal and his pain went away. So two things have to happen for pain to go away. Healing has to occur after an injury, and the brain has to turn off the danger alarm mechanism. If the brain doesn't turn off the danger alarm mechanism, yet there was healing, chronic pain can and will, or can ensue. So anyway, he's fine. 20 years later, he's walking down the street. He's startled by the sound of a helicopter in the sky. And at that moment, he gets the same pain in his leg that he had had 20 years earlier. His brain had learned pain as a neural circuit. What's a neural circuit? It's just how we do everything, right? How we talk, walk, smile, laugh, play catch, throw a ball. Everything we do and we learn is based on neural circuitry in the brain. And so he had a neural circuit for that specific pain, which got activated at the sound of a trigger, an innocuous stimulus that was turning on that was activating his brain, the danger signal in his brain, the alarm mechanism in his brain to turn on pain. So all pain is real. There's no such thing as real pain or imaginary brain, and all pain is created, generated, activated by the brain. And pain can be triggered either in the presence of tissue damage or in the absence of tissue damage by neural circuits in the brain. It's very simple, very straightforward, very powerful way of understanding what pain is. And the same is true for fatigue, and the same is true for insomnia, and the same is true for anxiety, and the same is true for depression, from my point of view. So this is a chart that I show all my patients because injury can activate the danger alarm mechanism, and so can stress. So research, I'll show you that in a minute. The danger signal activates an alarm, just like a smoke alarm, which are in the presence of symptoms. All these symptoms are a result of these neural circuitry. But the symptoms activate frequently fear and worry and anxiety and focus on the symptoms and frustration with the symptoms, and all those things feed back to the brain to further activate the danger alarm mechanism, which then further activates the symptom. So most people with chronic pain get worse over time because of this vicious cycle of pain leading to fear of pain, leading to more pain. And hence is an opportunity for us to interrupt this vicious pain cycle of chronic pain by reducing fear. And that's the first two videos I'll show you have to do with that. The other part, of course, is that sensitization of the brain occurs. Sensitization of the danger signal occurs from childhood trauma, from life stress. And that sensitization makes many people's danger alarm mechanism more likely to be activated later in life by other and new life stressors. So this study is a famous, important study from Ethan Cross, who's actually from the state I live in Michigan. And he did the study where he gave college students a physical pain on their arm with heat, and he scanned their brain with fMRI. Then he gave them an emotional pain, social rejection pain, which was showing them a picture of an ex-lover who had dumped them in the prior 6 months, and they're the same. The parts of the brain that light up with physical pain and social pain are the same. Very important study. And this other, I'll only show you this one other study, I think, where on the left slide you can see people with, it says SBPP. This is back pain persistent. So people at time 0, they started getting back pain, and in the red diamonds, it shows in their brain, the somatic sensory areas are very high, physical pain. And the blue circles, the emotion-laden areas, are much lower. But a year later, the blue circles become much more prominent and the red diamonds get low. The somatic areas are low, but the emotion-laden areas are high. Chronic back pain is an emotion null problem. This is a crazy and bizarre statement to make, but that's what our data shows, or these data. So how do we assess people? All right, so that's my section on predictive coding and what pain is. So I'm going to stop for a second and answer any questions at this point.
So anybody feel free to unmute if you want to ask a question.
Yeah, anybody who wants to ask a question, or you can type in a chat. There's something in the chat. When my baby was small, I could hear her cry when she wasn't. Yeah, you know how many people have had the experience where you hear your name being called when it isn't? This is an amazingly common experience, especially if you're waiting for something. Like if you've ever been in a surgery, you know, a loved one is having surgery and you're waiting in this, what we call the surgical waiting room, and they're called the different names, and you all of a sudden you hear your name called, and no, very common. What was on the second diagram? The second diagram was fMRI of the brain in people with back pain who had acute back pain that progressed to chronic back pain. And the difference was that in chronic back pain, the emotion-laden areas had increased, and the somatic, the physical-laden areas had decreased. Camilla, you have a question?
Yes, hi, thank you so
Hi.
much. Hi, no, actually that was basically my question. I think at first I thought you meant the opposite, that you had like an increased emotional pain in the beginning, and then over time it went away.
Oh, right.
So I was like, this goes against everything we talked about, but okay,
right.
This makes much more sense. Okay.
Yeah, yeah. It's shocking. I mean, I mean, everything I'm saying is just like, you know, most people, most physicians, maybe a lot of therapists as well. Like, what are you saying? This is it's so simple, but it really is revolutionary, I think. And obviously, we're going to bring it back to where therapy comes into play, and the two, you know, the way I see it, the two basic forms of therapy, the pain reprocessing and the emotional awareness and expression part. But what I'm starting with is a conceptualization of these symptoms so that we can know that they're what they are. And now what I'm going to talk about is how to diagnose this. How can we help you actually determine the difference between central pain or neural circuit pain and peripheral pain or body injury pain? Well, it turns out is extremely easy. Do you believe me? It's extremely easy. Okay, we shall see. I'll try to convince you of that. We'll take a poll. We'll take a poll. We should do a poll. Like, how many of you think that it's so easy that you can just tell, no problem? But at the end, we'll see how many you believe if I've convinced you or not. That'd be a good poll.
Sophia,
another question?
Yeah, maybe you can see it there. Can cramps that are not epilepsy be connected to dissociation? And is that then a form of PNEA?
Yeah, I'm not. I don't know exactly what you mean by cramps, but to me, a cramp is kind of like a muscle cramp or a seizure of the muscle, but a seizure, yeah. So, yeah, absolutely, absolutely. Any, you know, any physical symptoms that's not due to a structural cause is therefore I lump in the category of what we, you know, sometimes call psychosomatic. I love the term psychosomatic. We can't use it in America because people get mad at you. I think it may be a little more common on the continent that it's more accepted. But so I just tend to call it neural circuit, a neural circuit or a brain-induced symptom, because people often don't want to say, oh, it's psychological. They don't want to hear that, like it's their fault. And obviously it's not their fault. but it's more quote neurological, but it's not neurological in the sense of an actual damaged neurology. A seizure is an electrical event that that happens in the brain due to brain damage, basically. These are not seizures. So you're absolutely right. These are forms of PNEA. Good. Okay, I'm going to go back to screen sharing. Is that good?
Very good.
Okay. So what's the diagnostic process? It's very simple. First step, rule out a structural, rule out the physical disorder. And this is done basically by doing just normal routine testing. So that's why fibromyalgia is fibromyalgia, because we've already tested and ruled out lupus and rheumatoid arthritis and other conditions. It was the same with the seizure thing. You do an EEG, and you can do an EEG while they're having the seizure, and you can prove conclusively that it's not a seizure. With the back disorders, we'll talk about, I mentioned that, and if the MRI of the back does not show a tumor, a fracture, an infection, then we've ruled out a significant or serious problem, and the nerves are working. If you can stand on, if you have sciatic pain shooting down the leg, if you can stand on your toes, stand on your heels, if you can feel feeling in your legs, if the reflexes are normal, that suggests there's no nerve damage. But beyond that, we're going to rule in a neural circuit disorder, and that's why I gave you that case. All the clues that are in that case that I gave at the start, which I'm going to review in a minute, are there to help us confirm that there is, in fact, a neural circuit problem. Because it's not enough to tell people what they don't have. Because when you tell people, well, you don't have anything serious, but yet they're saying, yeah, but I'm still in severe pain, there's got to be something wrong. And their mind just constantly goes back to, there's something wrong with my body. There's something wrong in my body because I'm having pain. But our job is to explain to them that the pain is real and it's coming from the brain, and we can confirm that by ruling in a neural circuit disorder. And it's the same with anxiety. I mean, how do you treat panic attack? You can treat panic attack by helping people stop fearing the panic attack. You can treat panic attack by desensitizing them to the feelings of panic when that panic occurs. Just like you can treat snake phobias by desensitization process. And so that's a lot of what we're doing. And then the third thing is adding evidence that personalizes the disorder. Okay, so what evidence can we get for someone having a neural circuit disorder? And these are some of the things. There's a few more that I sometimes use, but let's start with the pain map. So when you ask somebody who's having a chronic pain problem, where they have had chronic pain in their life, where they've had episodes, not just they bumped their knee and it got better, but that they had significant pain over their lifetime, the more checks that they have, the more likely that they have a neural circuit problem, because their brain is more likely showing that their brain has been sensitized. I think Sylvia, you had a question? Or should I go on? If you feel free to interrupt me. The second thing is what we call a review of systems. This is part of typical medical practice. But what we're doing here is we're asking people to check which of these kind of syndromes that are likely to be neural circuit or brain-induced syndromes in their lifetime. So you can see this person in her childhood, she had stomach issues, headaches, anxiety issues. So something was going on in her childhood, which was creating all this stuff. In her teen years, she was having jaw pain and she was having palpitations. So something was probably going on in her teen years. In her 30s, she developed fibromyalgia. And in 1981, she had back pain, neck pain, et cetera. So this gives a roadmap for searching for the connection, the linkages between the onset or exacerbation of physical symptoms and the correlation of those with stressful life events. And this is just a graph showing that. This depicts a stress and hurt in a child who maybe has a controlling or maybe emotionally abusing parent. And then let's say she becomes her teen years, she has problems in school with school stress or relationship stress in school, or a boyfriend who betrays her, and now the danger signal gets higher and the symptoms start to emerge, such as migraine headache. In her mid-20s, she gets married, but the guy she marries turns out to be a jerk, maybe emotionally controlling, like a parent. The danger signal goes up, and now she may get irritable bowel syndrome or pelvic pain syndrome. And then, of course, later in life, maybe she divorces the jerk, but he's still trying to control her or turn the kids against her, and she gets in a little fender bender accident in a car, and then the danger signal gets higher. Now she gets neck pain, which proceeds to whole back pain, which then spreads to fibromyalgia or anxiety and depression. And now she feels like everything has gone wrong and she's completely broken physically, but she's not. It's just a normal course of events of a danger signal building up and getting reinforced over time in someone's life. And that danger signal crying out to say there's something wrong, crying out to say help. And the danger signal doesn't speak English. It speaks in physical symptoms. And this is just another way of connecting certain life stresses with when symptoms began or recurred. This is one of the simplest ways of asking, what was your childhood like? And so what I just gave to you was what I would call, these 4 areas are what I would call circumstantial evidence. They're things that make the diagnosis of a neural circuit problem more likely, but not conclusively, if you see what I mean. The next set of things that I'm going to show you is how to diagnose these more conclusively. In other words, confirm or rule in a neural circuit disorder. And the first way is by the localization. It's the symptoms. Where is the pain and what is it doing? So the pain is the whole one side of the body. Well, a whole side of the body can't be due to a structural problem unless there's a severe spinal cord injury or something. The whole leg, if you have pain in the arm or leg due to nerve damage, it's going to be on the inside of the leg or the back of the leg or the outside of the leg. It's not going to be the whole leg or the whole arm. So this kind of pattern confirms it's actually a neural circuit. It shows it's the brain. Isn't that easy? Pain that's in mirror image on both sides of the body. Most of the time, almost all the time, that's the brain, because the brain is just really good at producing pain in one thumb, and then it jumps to the other thumb. You heard one thumb, and then it goes to the other thumb. That's your brain. The injury occurs, and the healing occurred, as I said, but the pain continues. The pain shifts from one area of the body to others, and the pain spreads over time. If you remember that patient I gave you at the top, he started with neck pain, and then the pain spread to his lower back. That's his brain. Very simple. Secondly, the variation of pain, and thirdly, the triggers of pain. So the pain varies. So the pain occurs in the morning, then it goes away in the afternoon, then it comes back in the morning. That's your brain. The pain goes away when you're on vacation. The pain occurs when you're driving in the car, but not when you're sitting at on the sofa. The pain is tolerable or mild when you're walking or exercising, but 2 hours later or the next day, it's horrible, it's severe. So that's your brain, because if you have an injury, if your shoulder's broken, it's going to hurt when you move it. It's going to be better when you rest. And this is the opposite. The pain is triggered by sounds or light or computer screens or food or heat or cold or smells or the weather. The weather doesn't cause pain, even though everyone knows that the weather makes arthritis worse. It doesn't. These things are triggers for pain. They're triggering the brain to activate pain. We can talk more about that if you want. But again, these things, when you find those, we can help patients understand and see that it's actually the brain. And of course, pain that occurs in anticipation or during stressful situations in life. So these things are confirmatory. Here's just a slide showing a bunch of these together as a checklist that you might want to use to remind you what things to ask for. And when you're talking with patients, to confirm, to rule in neural circuit problems. Okay, ready for your quiz? So let's look at this slide. What does this tell us? Well, first of all, he's had neck and back pain for 11 years, so he's having chronic pain. What's the likelihood that his chronic pain is due to neural circuits in his brain rather than an injury? It's very high because most people with chronic pain do not have an injury. And I hope I tried to show that today. He had headaches beginning in his 20s, so that suggests that there was some neural circuit issues going on in his life, some maybe sensitization of the danger alarm mechanism earlier in his life. He had an episode of depression. Again, another more evidence to that sensitization of his danger signal and the fact that he's the kind of person who has neural circuit issues. He had an accident. He fell and hit his head. He had a bruise on his head. Did he have a severe enough injury? He didn't lose consciousness. The CAT scan of his brain was normal, and he had head pain for 2 days. So what happened to his injury when he fell and hit his head? The injury was relatively mild or even moderate, but it healed. And the problem has nothing to do with the injury. When did he develop neck pain? 6 days later. If he had hurt his neck severely during the fall, he would have had neck pain at the beginning, not 6 days later. Why did he develop back pain 6 months later? It wasn't due to another injury. He didn't re-injure himself, but the back pain developed most likely because of ongoing or building stress in his life due to the pain, due to his job situation, legal action, whatever else was going on in his life. Okay, so just in this part here, there's 1, 2, 3, 4, 5, or 6 clues to the fact that this is neural circuit pain. Okay. Secondly, he sought medical treatment, and medical treatment didn't work. That's another clue. The MRI shows nothing other than normal findings for somebody in their 50s. He had injections, it didn't help. He had surgery on his neck, but the pain got worse. Why did the pain get worse? Because his subconscious brain interpreted that surgery as an assault, as more danger. If you've had trauma in your life and you get an injury, well, the injury just feeds right in, or can feed right into that danger alarm mechanism as more trauma. And the same is true for surgery, because surgery is clearly trauma, it's traumatic. The pain is high despite all this medical treatment, more suggestion that it's not a simple physical injury. Now, other psychological stressors. The workman's comp situation is often fraught and difficult in our country. There's a lawsuit. He has a son with a substance abuse problem. He had a former drinking problem, so that, again, more evidence of neural circuit issues. His father was abusive, so he had childhood trauma. And now his mom is elderly and needs help. So there may be pressure there, and not clear what the relationship is there, but maybe more pressure on him to help his mom. And finally, the characteristics of the pain. So the pain turns on and off. So what does that mean, the neck pain? If it's turning on and turning off, that means it's neural circuitry, because physical injuries don't turn on and off. If you break your arm, the pain doesn't turn on and off over the course of the day. So this intermittency is clear evidence for confirming a neural circuit disorder. The pain is worse with cold or rainy days, more evidence. The low back pain, and the reason that his pain is worse with head movements of his neck pain is worse with head movements is because it's not because the neck is damaged, it's because when head movements are a trigger, and we can prove that. I think I'll give you a sense of how we can show that a little bit later. Excuse me. Moving to the lower back pain, the pain shifts from the right side to the left side. That's the same function. If it's shifting from one side to the other, that means it's turning on. One neural circuit is turning on for pain on the right. At the same time, it's turning off for pain on the left, and vice versa. The pain radiates up to the mid-back. And this whole thing is a spreading of pain, as I pointed out earlier. And the pain is worse with bending over. That's a triggering response. And it's worse in some chairs, but not other chairs. That's an inconsistency. Okay, so you want to ask a question? Robert, take a poll.
Charlotte is having quite a long question.
Or other questions at this point. My question is, how hard was that? How hard was that to actually, anybody, you don't have to have a medical degree, you don't have to have a psychological degree, you just have to have common sense, and you just have to have an understanding of how the brain works, and you have to have an understanding of predictive coding and what pain is, and you can just apply these principles by looking at what this person had. There are 15 clues in that little story that confirm that this is neural circuit pain. And so that's my question. How hard is that? Can you do that?
Maybe we can have a question on, can you please phrase the question?
What's the question? Do you, I don't know how to phrase the question. Now, do you think you would be able to evaluate people with pain to determine if it's structural or neural circuit? Yes or no? Or maybe. All right, there's a question here while you get that up. I wonder about gender perspective. There's a risk that make it harder for women, that these theories can make it harder for women to get help for physical pain. Doctors treat women and men differently. This is true. Doctors are, in the States anyway, there's a lot of research showing that the way pain is treated and the way women are treated is worse than the way men are treated. There's also a lot of research shows minorities and people of color are treated worse in the medical profession than the majority population, especially in relation to pain. And so, and I'm going to talk about how we can talk to people about that. So the next part of this is how we treat people. And the first way of how we treat people is how we talk to them, right? And so how we talk to them is critical, because if we talk down to them, if we gaslight them, if we're condescending to them, if we're making them feel it's their fault, we have completely missed the boat. We completely have misunderstood what we're doing. And so it's critical. You're bringing up a really, really important point about these disorders. And so a question, I'm wondering about the delayed pain. Is it possible that rewiring the brain after brain injury could explain later onset of pain? Yeah, that's exactly what it is. It's a rewiring. But you know, neural circuits rewiring of the brain changes when you learn to play the violin. The brain changes when you develop an anxiety disorder. The brain changes when you laugh. There's strong evidence that the brain is neuroplastic. So yeah, the brain learns pain from having pain. You get pain because of a physical injury. Your brain learns that pain through a neural circuit, and then that neural circuit keeps firing. And what do we always say? You know, Donald Hebbs, the famous Canadian neuroscientist, said neurons that fire together wire together. So that's exactly what's happening. And so, yeah, we're going to talk more about how to present this to people in just a minute. 75% yes, that's amazing. Look, and that was such a short course. So easy. It's amazingly easy. But the thing is, when you start to do this, it gets easier and easier. And there's some patients that it's very hard to do. There are some patients it's hard to sort out where you can't tell. And there's some patients that I can't tell. Okay, that's going to be the case. And there's some patients that have both. They have a combination of physical and neural circuit pain. That's certainly the case. So it's not always that easy. But I got to say, most of the time it is relatively easy. And I've been doing this for 18 years now, basically. Okay, let me move on. How are we doing on time? I think we're good.
Actually, several more questions.
Oh, okay. In the chat?
Yeah, in the chat.
Oh, okay.
From Jonna and Andreas.
Okay. How to present this to patient. Yeah, we're going to talk about that in a minute. A thought on the ruling out medical issues. How do we know the cause isn't unknown during the current? This is a really great question. This always comes up. Well, we don't know what the cause is, so, but it could be something that we will discover sometime in the future. And there's always, I mean, not always, but, you know, people could certainly worry about that. But number one, we have to treat people where they are now and make the best answer, give them the best answer we can. But number two, when you confirm, and I'll show you a video, I'll show you 2 videos of this where you can confirm the diagnosis based on your interaction with the patient. You don't have to rely totally on what I've presented so far. There's another layer of this that I'll show you in a minute that can really confirm this. Okay, yeah, so the other question, this is another great question, is what about chronic low-grade inflammation? I'm so glad you asked that. There are definitely studies linking inflammation to depression, no doubt about that, in the brain. My view on that is this is reversible. It's part of the neural circuitry. It's part of the learned pain, or in this case, learned depression. It can be unlearned. And so, number one. So the question is the inflammation the cause of the disorder or a result of the disorder? Hard to know, but if it's reversible with the disorder, it doesn't really matter. Inflammation in the body causing pain, in my opinion, is a misunderstanding of, is a conflating of 2 types of inflammation. Macroinflammation or localized inflammation. If you get a strep throat, you have a localized or macro inflammation that you can see. There's pus, there's inflammation, you know, there's redness, there's swelling. That can cause pain. If you have an infection in your knee, or if you have gout in your toe, that is a physical disorder that the inflammation is visible and obvious. That's macroinflammation. Microinflammation, everybody has. We all have microinflammation. We all have levels of inflammation in our body. We have inflammation in our gums. We have inflammation in our arteries. But this microinflammation does not cause pain. It's being suggested that it's the cause of pain, and it's being suggested, and this is where I get to offend more people. It's been suggested that we need to change our diet to a lower inflammatory diet to reduce chronic pain. This is not true, in my opinion. You can change your diet. If you change your diet to a lower inflammation diet, it might be good for you in the long run. If you become a vegan, you probably will live longer. That's a good thing, but it's not going to affect pain because pain is not the result of microinflammation. Now, we could talk more about that if there's more questions, but is it trauma that causes a neural circuit disorder? Yes. Well, it's trauma that sensitizes the brain early in life. We all have some form of trauma or some form of distress. And then it's later trauma or later life stressors that activate the danger signal in the brain. So it's a priming effect and then a triggering effect. It's a simple way I would describe it. Let's see, what else? I've met patients where their pain or physical symptoms gotten worse of how they were treated by doctors. 100%. I can't tell you how many people were doing emotional expression work because they're angry at their doctors. Absolutely. This is a horrible situation, but incredibly common because the doctors are saying it's all in your head, and that's enraging, right? What I tell people is anybody who says the pain is all in your head is either cruel or ignorant or both. Because when they say that, they're implying that the pain is imaginary, it's your fault, or you're making it up, or you want the pain, or you're crazy, or you're mentally ill, or you're deficient. None of those are true. And I would suggest you that's what I do, and it works every single time. Anyone who says the pain is all in your head is either cruel or ignorant or both, because they're implying it's your fault. And that is not true. The pain is real, all pain is real. And we're just gonna figure out where it's coming from so we can help you get better. Can you say something on working on untangling the somatic and psychological part of the patients with a combination of the two? Well, you can't assume it's a combination of the two. Let's put it that way. A lot of people, when you start, if it's an assumption that it's a combination of the two, that's usually wrong. It's usually neural circuit pain with chronic pain, as I pointed out. But how I untangle it is by what I just presented to you. That's exactly what I do. And the stuff I will present you in a few more minutes. Stuttering, I do believe stuttering is the same. It's a neural circuit. Okay, good. Great questions. Thank you. Okay, let's finish up this part and I think in the next 10 minutes, and then we're gonna talk about some of the research. Okay, share slide. We good?
Amazing.
Amazing. Amazing. My son and his partner helped me redo my slides to make them a little more pleasing to the eye. I had horrible looking slides. These are a little better anyway. Okay, so we're making an accurate diagnosis. We're educating, as I pointed out, how to do that. We're educating on the nature of pain, which I did with predictive coding. Everything that I told you about the nature of pain is exactly what I tell my patients. And then we're doing rewiring the brain, pain reprocessing. I'll show you examples of that. Graded exposure, it's another basically desensitization. I'll show you a little bit about that. Emotional processing, and then some people clearly need to make changes in their life if they're in an abusive situation or they're in a job which they hate, or they're having issues with a child or a neighbor or whatever. So back to this diagram, we're showing the pain circuitry and how we can interrupt the pain circuitry or the fatigue circuitry or the depression circuitry or the insomnia circuitry, et cetera. It's all the same in my view. We can interrupt that by reducing the lower left, reducing the fear, and also working on the actual emotional part, the sensitization and the stress part of it. Okay, let's talk about pain reprocessing for a moment. What we're trying to do is make the pain less dangerous, reduce the fear of the pain. Pain is fed by the reaction that we have to it. We can't control the pain because the pain is driven by a subconscious part of the brain, but we can control our reaction to it, how we view it, how we respond to it. And so we're demonstrating inconsistencies in the pain response. We're giving hope. We're helping people be optimistic. We're giving them confidence in the diagnosis. We're showing them, we're demonstrating to them. I'll show you that in a minute, how we're demonstrating to them how the pain can shift or move. And we're communicating this diagnosis with certainty. I have people take a quiz. The quiz is what's wrong with you, and the answer is nothing. It's an extremely useful quiz, I find, because when they say nothing, I tell them that's the right answer because I've already confirmed it. But when they say nothing, I go, how do you feel about that? Because most of the time they'll say, well, it's really nothing. I don't know. I doubt it. Good. Let's address the qualms. Let's address the doubts. Let's work with this over time so we can prove what's going on, so we can see it in your own life. We can demonstrate it. And then we're asking, how do you feel toward the pain? Because most people hate their pain, right? Most people hate the fact that they can't sleep. They hate the fact that they're depressed. They're resentful. It's annoying. They feel like their brain is betraying them. But the symptoms are protectors. Our brain is trying to help us. Our brain is trying to give us a message. We don't get mad at a smoke alarm when it goes off. We look for smoke. We look for the underlying cause. The sound of the smoke alarm isn't the problem. The problem is if there's a fire or not. And it's the same with pain. And so I ask people to begin to set aside their view of the pain as something that's attacking them, as an enemy. And I prefer to ask them this question: what would you do if your child or your grandchild was lying in bed at night afraid of a monster in the closet? And most people would say, I wouldn't be mad at them. I would comfort them. I would have compassion for them. I would open the door and show them there's no monster in the closet. I would sit with them. I would soothe them. Well, that's exactly what people have to do with their own brain. They have to soothe the danger signal in their brain, which is afraid for them. It's afraid of the things that have happened in their life or the things that are going on in their life. And it's producing pain or other symptoms as a response to that. And people can treat themselves and their brain without anger. They can treat their brain with curiosity to see if they can understand what the message is. And they can treat their brain with compassion and calmness. This is a huge shift. And this shift can reverse the whole cycle of pain, fear, and pain. And I'll show you that in a minute. And then we're using mindfulness, or what we also call somatic tracking. Now, I told you earlier, mindfulness is not that effective for chronic pain. The reason is, in my opinion, is that mindfulness being used for chronic pain is saying, well, you can be aware of your pain and watch it and observe it and separate from it. But, excuse me, sorry. But if you're viewing the pain as being due to a physical problem, you're taking that pain and you can watch it, but you know it's not going to go away. But if you take the pain, you take the back pain or the headache pain and you put it in the category of a thought, mindfulness, I'm sure a lot of you have studied mindfulness or practicing mindfulness. When you put the headache or the stomach pain in the category of a thought, now you can do mindfulness in relation to thoughts. Well, we know thoughts are generated by our brain. And the most liberating part, in my opinion, of mindfulness, in my experience, has been in being able to notice thoughts rather than react to them. And then we empower people to begin to take back their life and to start moving and bending and living their life and going out with the assurance that they're going to get better. Okay, so what I want to do now is just mention, of course, the emotional component. So I said EAET is stolen from ISTDP. I'll tell you that story in a minute. We have lots of studies. There's 21 studies now, randomized controlled trials of ISTDP. Alan Abbas has just written another update on this, another meta-analysis that I was fortunate enough to participate on. And it's showing that the effect size, the efficacy is more powerful in general than standard cognitive behavioral therapies. And it tends to be very long-lasting benefits. There's great outcome data on ISTDP, as you probably know, showing great dramatic reductions in hospitalization and disability. And what we're doing in terms of the adaptation of EAET is basically going to the hurtful experience, getting in touch with feelings, often anger, expressing anger, accessing guilt, expressing sadness and grief, moving to love, compassion, and letting go. So these are steps. These are the, you have access to the first 5 chapters of one of my books, Unlearn Your Pain. In later chapters, I've tried to take this model and make it very simple, make it very step-by-step. We're teaching patients to do this for themselves. And people can do it. It's not as in-depth as, you know, ISTDP. It's not as interactive, and it's not as focusing on micro changes in feelings. It's just a little more, you know, whatever, a little broader strokes. And this is just a description of that in visual terms. I'm going to move on. And what I tell people is, well, we can't change your past. And I'm going to show you descriptions of this, or I'll show you, you know, some examples of this on video in the second half of our time together this afternoon. But I tell people, you know, you can't change your past. But how do you know what your past is? Well, your past, we only know our past because of our memories of the past. And our memories are constantly changing. Every time you remember something, it changes. And you can remember things over and over again, and they can get worse and worse and worse, or they can get better. So we can actually use memory reconsolidation and rescripting of memory as a way to change emotional memories and as a way to free people from their past. This is from Alan, a quote from our book together, Hidden in Plain Sight. That's so funny that the book is called Hidden from View. The original title was Hidden in Plain Sight, but we had to jettison that because there were 20 other books with the same title. Anyway, what he's saying here is just kind of the basis of ISTDP, which is the basis of EAET. Okay, so this is, I'm almost done with this section, and then we'll have questions, and then we'll go to looking at the research. So here's a simple way to talk to people. You can say headache, back pain, fibromyalgia, whatever the symptom your client has produced pain that's 100% real and often severe. I'm so sorry you've had to suffer from this. I want to do anything and everything in my power to help. You're using all these medical treatments, but yet you're still having pain, or you're still having fatigue, or you're still having anxiety. And the other thing I found is really, this is how I learned this basically, is by talking to people over the years. What would happen is people their pain would get better and then they'd get very anxious, or their anxiety would get better and then they'd get pain, or their pain would go away in their head, it would move to their back, or their fatigue would get better and they'd have more pain. And so these symptoms are all interchangeable, and you see it when you work with people. And then when you recognize that, you're getting more proof that these are neurocircuit problems, because they're turning on and turning off, because the danger signal in the brain is still activated, and since you haven't been able to calm it down yet, it's producing different symptoms at different times. So you're doing all this stuff, yet you're still having these symptoms. Many people with pain or these other symptoms have found success with an approach that allows them to take more control over it. Do you want to learn more about this? Very simple. It's up to them. There are certain signals in your history suggest you might be a good candidate for that. The pain map shows this. The checklist shows this. The fact that you've had trauma shows this. The fact that the symptoms are inconsistent, that they vary, that they're triggered by a variety of things. These are all clues that suggest that you could have dramatic reductions or even reversing pain the more we look into it. And I've had patients who really like this. Do you want to read about it? Do you want to learn a little bit more? Some people found they can make dramatic changes. So it's very simple, reinforcing it's not in their head. It's real. Their suffering is real. But educating them to the fact that real pain can and is frequently caused by neural circuits in the brain that are not imaginary. They're circuits. Those are real. Okay, and then there's a bunch of resources that you can give to people to go to. There's a bunch of books that have been written on this. There's textbooks. There's 2 textbooks. All these books are for patients or clients, but the 2 that are for professionals is the Hidden from View one that I wrote with Alan Abbas, and the bottom one, which Alan was also an editor on, as was I, a psychophysiologic disorder textbook, which is available from this website, the PPDA, the fifth one down, the PPDA Association, a nonprofit that we started in the States. So a couple documentary films that you might want to look at. I can give you where to find those that have been made that are kind of fun to watch and hopefully are good. Okay, let me stop for questions before we get to the research studies.
There's a question from Emilia.
Yeah.
Do you see it?
Yeah, outcome, independence, and great exposure. Yeah, I skipped over that because I was feeling short of time. Graded exposure is I'll show you example of graded exposure in a minute. It's just classic desensitization. You give people an exposure to a low level of the pain, a low level of the trigger, like bending over, and then a little bit more and a little bit more, or a low level of You know, you do it with anxiety disorders, a low level of anxiety, like with snake phobia, and then a higher level. Outcome independence is just a term we use to describe where you ask the patient to focus on doing things without fear. That's their goal. Your goal isn't, I tell people, your goal is not to make your pain go away. Your goal is not to reduce the pain, even though it obviously is. Your goal is to stop your fear of the pain. The process to getting to reducing pain is to reduce the fear, to reduce the focus on it, to reduce the frustration with it, to change your relationship to it. When you change your relationship to it, that lowers the danger signal in your brain, and that lowers the pain. So your measure of success shouldn't be if you're having more pain or less pain in the short run. Your measure of success is actually if you're having more or less fear of it. That's outcome independence. There's a couple more that I'm having trouble with my Swedish. Someone want to translate for me?
It was just a question about a translation of neural circuit into Swedish.
Oh, okay. Yeah, sometimes we, in English, we'll call them neural pathways, neural circuits, you know. Any other questions before we go to the research?
I have a question.
Yeah.
Hi, so I'm just wondering a little bit, because now when you're talking about pain and what do you say, the outcome independency was the idea that you lower people's fear of pain.
Right.
And that will, yeah. But I'm just wondering, that's very close to what ACT is, I think. Like,
yes.
So I'm just, you said that, but and there you don't actually see that much pain reduction. You see
right.
of what do you call it, quality of life, because you do
yeah.
things that you're afraid of. So I'm just wondering.
That's a great question. That's a fantastic question. Yes, the techniques of ACT are excellent. The techniques of cognitive behavioral therapy are excellent. There's nothing wrong with those techniques. The reason, in my opinion, as I think I tried to point out, the reason that they have less efficacy is that they're not being used, in my opinion, in the correct context. They're being used. The first rule of ACT is we're not here to make your pain go away. We're here to help you cope with this better. That sets up a ceiling effect. It sets up that, you know, we'll use these techniques, but they're not to actually make the pain go away. So it reduces hope. It reduces optimism. The techniques are fantastic, but we're making an accurate diagnosis of the pain to start with. And we're giving hope and we're explaining pain, the whole pain education, right? And then we're using methods which are geared toward eliminating pain as opposed to methods which are geared toward coping with pain. Now, and some of those methods are the same. So like I just pointed out, mindfulness, we use mindfulness, but we're using it in the context of neural circuit pain as opposed to the context of physically induced chronic pain. And to us, that makes a huge difference because we're taking the pain and we're taking it out of the category of a physical injury and we're putting it into the category of a thought. And so when you do that, when you tell people that we're going to use these techniques that are in ACT to make the pain go away because your pain is a neural circuit and it can, now those techniques will be more effective. That's how I see it.
Okay, thank you. That's really interesting.
Let's see, the slides. Yeah, the slides are all available on the Facebook page. Vulvodynia is a neural circuit problem. That's a simple question. It is. There's no damage. I see it all the time. Would you say that less fear of pain equals acceptance of the pain? Yeah, you're accepting the pain experience, but you're not accepting, this gets back to ACT and ACT. You're accepting the pain experience for the moment that it's there, and you're accepting it as being okay. You're taking the pain and making it less dangerous, less worrisome. You're allowing yourself to separate from it and observe it and actually make it less unpleasant. Yes, you're doing all that, but you're not accepting that it's going to be there forever. You're accepting it as a method of making it go away. That's the distinction that is really important. Okay, let's go to the research. We have 20 minutes. We're going to take a break. Okay, so just a couple studies that we want to go over. Okay, so this is, so I'm going to show you basically three studies, two on using pain reprocessing therapy, and two on using EAET. And you might have seen some of these. You probably haven't seen this one because this one hasn't been published yet. So we did the study at the University of Colorado in Boulder, and there were 3 arms in the study. There was a randomized controlled trial. 50 people got pain reprocessing, 50 got a placebo injection, and 50 got a waitlist control. And they all had fMRI of their brain as part of the study. The average age was 41, so relatively young population. However, the mean duration of back pain was 10 years. So these people has been suffering with back pain on an average of 10 years. The educational level was high. Boulder, Colorado is a college, a university town. And I assessed, of the 45 people in the pain reprocessing therapy, the mind-body intervention arm, I assessed 45 of them. And my conclusion was 43 of the 45 were definitely non-structural in nature. 43 out of the 45 were definitely neural circuit pain. That's 95%. That's amazing. All of them had MRI abnormalities, but I was using the criteria that I gave you. 2 of them I wasn't sure about. I thought they might have been combined, structural and non-structural. It turned out the 2 that I thought were combined actually got better with the treatment, as you'll see. So what's pain preprocessing? It's confirming the diagnosis. It's exploring the evidence to support the diagnosis. It's changing the meaning of the pain from a physical damage situation to a neural circuit that's reversible. It's using semantic tracking and mindfulness to alter the relationship to the pain. I'll show you that on a video. It's creating a positive mood, instilling expectation of relief, and it's using graded exposure to triggers to gradually expose more and more to these triggers to reverse them, to unlearn them, so to speak. We didn't use any emotional processing in this study. The results, of the 44 we treated in our category, of the 44, 33 were pain-free in 1 month. That's roughly almost 75%. That's amazing. 33 of the 44 were virtually pain-free in 1 month with 8 individual counseling sessions with a pain reprocessing therapist. The data showed the dramatic reduction in pain compared to the other 2 groups. The persistence of reduction in pain went up. We now have 1-year data showing persistence of reduction in pain, which is this 8 sessions, 8 counseling sessions, and the one diagnostic session that I did. So that's the PRT study. The excuse me, the EAET study we published a couple years ago now. Mark Lumley is my incredible, brilliant colleague. Robert and Dan know him very well. He's just an amazing, smart, brilliant, kind, humble, much better than me. Researcher, psychologist in Detroit, Michigan. And we put this together. He wrote the grant because he's smarter than me. This was an NIH-funded study from 3 different hospital settings, and 230 people, mainly women with fibromyalgia. These were 8 small sessions in group using EAET versus cognitive behavioral therapy versus an education-only group where they just got education about fibromyalgia. In the EAET group, we reviewed for them what symptoms are, the connection between life events, trauma, and stress, and their physical symptoms. We help them experience and express feelings of anger, guilt, sadness. We help them develop compassion and forgiveness, and we help them to deal with troubled relationships in their life. This was all in small group settings. Most people were totally new to this form of therapy, where we actually encourage people to experience and express emotions rather than manage or control or regulate emotions. The results were dramatic. If we're looking at 50% pain reduction post-treatment in that 6-month follow-up, the 6-month follow-up was even greater in the EAET group. 22% had more than 50% pain reduction, which is very high pain reduction for fibromyalgia, compared to 8% in the CBT group. In the terms of the number of people who no longer met the criteria for fibromyalgia at follow-up, that had reduced by 28% at 6 months later in the EAET group, and it reduced only by 5% in the cognitive behavioral therapy group. And the people who were doing cognitive behavioral therapy in this study were experts in cognitive behavioral therapy. They believed in cognitive behavioral therapy. And so it's what was called an allegiance-controlled study. It wasn't like the people who were doing the CBT were actually didn't think it was going to work. They thought it would work. And it does work, but only to a small degree. And then the last study that I'll show you, and then we want to show, Daniel and Robert want to show you the study that they did. So we'll have time for that. This study was done by our colleague Brandon Yarnes in California, Los Angeles, UCLA. And he has access to a patient population of military veterans with chronic pain who are older, in this case only older than 55, but still military veterans older than 55 with chronic pain. That's a very difficult group to reduce their pain in. And he compared, it's a small study, but the results were dramatic when he compared an EAET intervention to a standard CBT intervention. And you can see on the left that the reduction in pain in the EAET was way more than the CBT, where they had virtually no reduction in pain. And if you look at the percent improvement post-treatment in the first 3 bars, and then follow-up 6 months later in the final bars, you see that the CBT in the blue doesn't barely even make the graph. Only 5% of people got 30% reduction post, and none of the people in the CBT group had 30% reduction in follow-up. But yet, if you look at 30% reduction, it went from 35 to 38%. It went up over time. 50% reduction, 29 to 31%. And the 70% reduction in pain in this difficult to treat population was 12% at post-treatment and 23% 6 months later. That's a pretty amazing study. I mean, really, this study has just been published like last week, I think. I think it just got published in a journal called, I think it's in Pain. I'll get you the, I think I sent the article to you guys, if I'm not mistaken. Okay, I'm going to stop sharing because my transition will be to the video demonstrations. And Daniel and Robert, do you want to review the EAET study that you did?
Sure. I would like to say something about that. Of course, we want to take this amazing research to Sweden, right? So we tried to, our first study was a pilot study where we used the techniques that Howard described, but we did it in another way. So we did an internet-administered emotional awareness and expression therapy. So we actually had no interaction face-to-face. Patients and therapists, they met online or spoke online. Patients read material and conducted homeworks online. And as you can see, I'm sharing the screen, right? I hope, yeah. As you can see, there are a lot of people involved in research. We need that, not just me and Robert, Howard, Mark, Lumley, and Rosemarie and Josephine Ek. You need a lot of people to actually do good research because you need a lot of therapists, assessors, and people trying to do the study as good as possible. So we had in our pilot study just a small sample, but that's normal when we do a pilot study. It was 52 patients, and the internet administered EAET consisted of 9 weekly modules. And as Howard have expressed, we focused on emotional awareness and exposure. And because of the format, the therapist and the patient, there were no sessions, so we used something called expressive writing. Maybe some of you have heard about it. It's a really amazing method where you can process feelings of anger, guilt, sadness, love, etc. by really using writing to be able to connect to your feelings and express them. This was one of the things that we did in the study. I won't talk more about that, but so if some of you are familiar with research, this slide makes sense for you. You can see something called effect sizes. It's in research, you usually have a primary outcome when it's the most important outcome. And of course, here it is somatic symptom reduction. And what this really slide tells us is that people did get a lot of relief from their somatic symptoms. For example, they did get a relief from pain and things like that. There was a so-called large effect. We also studied secondary outcomes like anxiety, depression, functional disability, and these were, and there we had small to medium effects. So, and I think Howard, you talked about actually that how much pain reduction can there be in a treatment like this, and here is a slide showing the proportion of patients who had the symptoms at least 50% reduced. And I compared it with your study, the study of that Howard talked about, and you can see that about 1/3, 1/4 of the patient actually do get significant reduction in their pain or other somatic symptoms. So I think this pilot study for us meant that we were able to go through to do a more controlled, we want to do a more controlled study here in Sweden as well, because as of now, EAET has only been studied in the United States, actually. So for all of you who are listening now, I just want to tell you, just of today, we are open for applications for our randomized controlled trial. We need to be able to conduct this study properly. We would need to include 160 patients, and 80 of them will receive EAET and 80 will wait for treatment. It will be an internet administered trial with the patients will have help from therapists online and doing reading and continuous homework assignments. And the treatment will last 10 weeks, and we will start, if possible, in February. So if you know patients or yourself a patient who wants to sign up for this, just go through our website, mbsstudien.se, to sign up. And if you have questions about this RCT, send it to me, daniel.maroti@ki.se. And I will be happy to answer all the questions. So join in doing this research. Back to you, Howard.
Thank you so much. It's so, as you pointed out, it's so hard to do research. It's so hard to do quality research, but you've done it, and you're moving forward to the next level, even harder to do randomized studies, but nevertheless, so important. And it's amazing that with an internet administered version of this, the results are fantastic. You know, it's hard. I mean, it's really hard to get people to, you know, to help people with, you know, with chronic pain, because chronic pain means oftentimes it means their life has been traumatic. You know, these are people often very damaged, often very fragile. And these concepts are hard. They're so counterintuitive. You know, the concepts of pain is in the brain, that's counterintuitive. The concept that that chronic pain can get better, that's counterintuitive. The concept that you know, that you need to identify and go delve into your emotions. You need to feel your emotion. You need to express your emotions as a way to get better from chronic pain. That's completely counterintuitive. And, you know, so it's an uphill battle, but yet we really feel, and I know you feel that, you know, we're beginning to make progress, and we're beginning to show that we can have dramatic effects in not everyone's life, but some people's life. And we can even do it through books and through reading and through internet. And it's really exciting. I mean, we are really, I believe we're on the verge of a paradigm shift in how we look at chronic pain. So maybe take a couple more questions and then we'll break. We got 3 minutes before the hour. People who practice mindfulness, you know, okay, so people who practice mindfulness, I mean, it's not to say that mindfulness is never going to work for chronic pain. Of course it will. ACT will work for chronic pain in some people. Anything that makes the brain feel safer can work to turn off the neural circuits of chronic pain. If the pain goes away, then it obviously was due to neural circuits. We can confirm that. I mean, I had a patient who I treated for, you know, fairly intensively for, you know, 6 months or a year, I don't remember, but I didn't help her at all. She didn't get better at all. She went to Brazil, she went into the rural areas, she visited John of God, she laid down on her back, she looked at the sky, she put her hand over her heart, she said a prayer and her symptoms vanished. She felt safe. That made her brain feel safe. And sometimes people will get better with diets. You know, they change their diet and their pain goes away. Yeah, of course, because that gives them a sense of control. So what we're talking about is the power of the brain. We're talking about the placebo effect, and we're talking about faith healing. And I view my work as faith healing. You get people to believe that they're not damaged and they get better. I view my work as being as activating the placebo effect in people's brains, because the placebo effect is a neurological response. The placebo effect is neurological. You're changing people from feeling unsafe at some deeper level to feeling safe. And there's 100 ways of doing that. And whatever works is good. But the point is when it works, what we're pointing out is why it's working. Because when people get, you know, a massage or an energy, a Reiki treatment or whatever, they think they need those energy treatment or massage forever because they're dependent on the treatment, but it's actually changing their own brain. And what we're trying to do is help people be in control and be empowered to change their own brain, to understand that they can do this. Okay.
There are a couple of questions, but maybe now is time.
Yeah, maybe we should break. Yeah. I can take more questions after the break. Yeah, thanks much. It's right on the hour. We on the same time? I mean, we're not in the same time zone, obviously, but the hour is the same. And so is 15 minutes good, or? Yeah.
Sounds
okay.
Great.
Let's do that. We'll see you in a few. Thanks.
Thanks, Owen.
Okay. How's it going? Good. Are we ready to reconvene? Are Swedes known to be on time kind of folks, or not so much? On time? This seminar is running right on time, I gotta say. Let's see. So can I keep going? Okay. Let's see. So there's a couple questions. Questions that I got in the chat just at the end there were related to like what kind of patients reject this therapy. All patients. It's like I say, this is counterintuitive from my point. This is just counterintuitive to what the norms are in every way, shape, or form. And every step of the way, it's counterintuitive, or certainly can be. So, our job is to meet people where they're at and start slowly and gradually introduce them to the concepts, and doing it with love and caring. Love is the magic ingredient that makes relationships work, that makes therapy work. It's what binds people together. If someone feels you care about them, then they're more likely to listen to you. The client-therapist relationship accounts for over half of the variance of therapy in general, before you even do anything, no matter what kind of therapy you're doing. So, yeah, but I think over time this will get better. I think over time, more and more people will be more accepting of this therapy, more therapists and more clients and more patients, because it'll become more the norm, little by little. And at some point there'll be the famous tipping point where it'll be much more widely used. And it's interesting that as someone kind of pointed out, the studies have all kind of similar results. The PRT study even had the best results of all, and they didn't even deal very much with emotional processing, but they were really good at helping people feel safer. Really good at helping people feel safer in relation to their body, in relation to their symptom, in relation to whatever. Yeah. So a question on exhaustion disorder, yes. We don't have any studies of that, but it's certainly, we treat fatigue and exhaustion in this way all the time. Okay, so let's go to the videos. I'm going to show you two videos.
Sorry. There was actually one more question from
Peter, yeah, sure.
From Peter Liljengren, who asked about, can you say more on the importance of emotional processing?
Say more on what?
on the importance of emotional processing.
Oh, the importance of it.
Yeah.
Well, the way I look at it, I have like a step-by-step approach in general. I don't think everyone needs emotional processing to get better, at least in the short term. I think emotional processing may be important for everyone just for dealing with life, with living, with being human. Human beings are emotional beings. And if we don't learn how to process emotions as part of our lives, we're missing out on a really important part of health. But the way I treat people is by first doing the assessment, as I pointed out to you, by making an assessment, a diagnosis, by educating about the nature of the brain and the nature of symptoms. Then I do the PRT work, and then I go on to the emotional work as it's necessary. Not everybody needs that. Some people get better just with the diagnosis and the explanation. That's enough to make them feel safer and to free them from the neural circuits if they don't have, you know, typically are people who may not have significant trauma in their life. So I just play it by ear, and but I always have the availability of doing emotional processing as necessary. We don't have data on emotional processing work for exhaustion. We don't have data on that. We need to do that. Another question about the role neural circuits play in the symptoms of asthma. Yeah, asthma is an example, great example of in essence, a structural disorder that has a powerful brain component. So I probably would put it as a combination. We treat people with asthma with medications, et cetera, but there is no doubt that asthma for many, many people can be treated by the exact thing what we're talking about today, by all the factors that we're talking about today. There's ample data to show that emotional issues can and often do play a role in asthma, as is the case with things like rheumatoid arthritis or lupus or inflammatory bowel disease like Crohn's or ulcerative colitis. So again, those can certainly be treated medically, but there's reasonable suggestion, at least in the data, that emotions can and may play a role for many people. The brain can certainly influence the immune system. So autoimmune disorders can certainly be influenced. The brain can influence the immune system in relation to allergies, and that's where asthma comes into play. So that's good questions. Appreciate that. Let's see, is there a similar psychodynamic diagnosis process in EAET that is stressed in ISD? No, you know, that's one of the ways that EAET I think is less involved and maybe light or simpler than ISTDP. There's less of a diagnostic process. There's less of the what do they call it? The trial, I think they call it, the ISTDP trial, which is a good time. So let me tell you that story. Let's see, it must be 10 years ago now, 8 or 10 years ago. I'd heard about ISTDP. I read an article by Alan Abbas, and it basically made almost no sense to me. It sounded phantasmagorical. It sounded, you know, way out there, but something about it, and just really was like, wow, this is something amazing might be going on up there. So Mark Lumley and I went to Halifax, and we took the 4-day immersion course. I knew nothing about it, and I'm not a therapist. I mean, I'm a physician, you know, masquerading as a therapist, basically. And because I've had to learn because I needed to help my patients. Anyway, so I take the 4-day course, and at the end, Alan and I had bonded a bit, and I said to Alan Abbas, Alan, should I be doing this? And he looks at me, and he says, Howard, you can't not do it. He looks at me, of course, he's 6'9", so he's, you know, staring down at me. He says, you can't not do this. Well, when you learn ISTDP, it takes like how long? Like years, basically? And he's telling me in 4 days, I can't not do it. I mean, I don't know what he was thinking. But anyway, I went home. The next day, I get home, the very next day, the very first patient I see is this woman in her 50s who had a conversion disorder. So it was clear she had a psychosomatic disorder. There was no doubt about what the problem was, but she was in a wheelchair because she couldn't walk. Her legs would not work. And she had been through every kind of therapy imaginable. Her psychiatrist had given up on her. She had been through my program at the time, which had done nothing for her. And she also spoke in this kind of funny dialect. It sounded like she was speaking kind of like childlike, really, just odd. But anyway, that's how she spoke. I'd never heard her speak in any other way. So I said to her, you know, I was just in Halifax and I learned these kind of new ideas. Nothing else has helped you. Would you be interested in looking at this? And she said, sure. So I said, okay, well, I didn't do a psychodiagnostic trial or anything. I just said, let's have you imagine going back to see yourself as a young girl. Let's have you look at yourself as a young girl and see what that feels like and see what you notice. And she says, well, she closes her eyes and she goes back to visit her younger self, and she sees her younger self as being maltreated, being ignored by her mother, being abused, yelled at by her mother, being abused by her sister, being abused by her brother, being neglected by her father, who was always gone away. And I said, how does that little girl feel? She said, that little girl is really upset. She's hurt. She's crying. She's ashamed. And she's angry. And I said, well, if that little girl could get in touch with her feelings, she would be hurt and afraid and everything. But if she could get in touch with her anger, what would that anger feel like? And she said, well, I can just feel it now because she was so angry at how she was treated. And I said, what would that anger want to do to express itself? And she said, and I swear to God, I'm like thinking, like, what am I doing here? What am I saying? I have no idea what I'm doing. And she says to me, that anger would take my mother and it would nail her with nails to the wall. And they're kind of obviously religious metaphor. It would nail her to the wall and her blood would come out and drip down. And her body would turn into dust and ashes. And I'm going like, okay, yeah, go on. And that would do the same thing to my sister and my brother. And I'm like, oh my God, have I ruined this patient for life? What have I done? And I said, well, how do you see that little girl? She says, I see that little girl as being broken and damaged and hurt, and she's wearing ratty clothes and she's unwashed and her hair is uncombed. And I asked her if she could express love to that little girl who was her in her imagination. And she just imagined holding and rocking that little girl for a few moments and talking to her soothingly. And I didn't know what else to do. And I said, so maybe you could just take some deep breaths and calm and breathe and come back to the moment. And she comes back, she opens her eyes, and this takes 20 minutes. And I say, so how do you feel? She says, oh, I'm okay. I said, are you freaking out? No, I feel calm. I feel okay. I feel like a weight has been lifted off of my shoulders. Okay. So she goes home in her wheelchair, and I call her the next day because I'm so afraid that I've ruined her life. And she answers the phone, and I don't recognize her voice because her voice is now normal. She's not speaking in that childlike dialect anymore. And she hasn't been in a wheelchair since that day. And I'm like, my God, what is going on? This is amazing. And I don't even know what I'm doing. And yet this tapping into emotions, allowing emotions to be identified, recognized, expressed, allowing people to express emotions without dampening them, allowing people to express compassion for oneself, so powerful. Anyway, so that was that's how I got into this. And I've been hooked ever since. So we tried to figure out ways to make it, easier to use for people like me who aren't going to do, 2 years or 4 years of ISTDP training. I'd rather be an ISTDP therapist, but Not. All right, so let's do some videos here. Let's see.